Dr. Sadir Alrawi, Senior Consultant Surgical Oncology from the United States, from the Cancer Care Specialties and its satellites in the Middle East, talking about today difficult thyroid cases and their management in the Middle East. Most of the thyroid cases that come to us are not this straightforward because general surgeons will take the straightforward cases by themselves. However, the cases that come to us are complex with a difficult decision that need teamwork in order to get that handled and have solution for these difficult cases. Most of the cases that come to us with the big enlargement mass in the neck, sometimes with the lymph node enlargement on the both sides, that will delineate the need or necessity of any investigation. 90% of the investigation coming through an ultrasound, which is high resolution. High resolution ultrasound will replace CAT scan, MRI, and PET scan in handling these complex cases. Diffuse thyroid enlargement with the thyroiditis with a small nodule in the lower part, big nodule on the left part, which is thyroid 4, vascularity and elasticity of the thyroid are mandatory. We will work the patient including thyroid function tests, including T3, T4, and TSH, and the thyroid antibodies. These are very important in order to know future functionality of the rest of the thyroid if we are planning for doing hemithyroidectomy. From these, we have an idea about 90% about the condition of the patient. From also, one of the recent cases that came to us, even with the high resolution ultrasound, you can see the difficulty of a patient that had right hemithyroidectomy in the past and now going from the completion or difficulty in understanding the rest of the thyroid. Big thyroid nodule in the remnant, calcification, irregular boundaries. This is making it as thyroid 4 and possibility of thyroid 5. That FNA preparation is mandatory in this case. Based on that, a nodule with the thyroid 4, including the size 1.4 and 1.3, with the irregular boundaries, with the calcification in the middle, vascularity, this is a thyroid 4 or thyroid 5 that need to take in consideration also FNA. These are the cases that come to us, sometimes with the lymph node in the neck, which we need to biopsy it. However, also need in consideration difficult thyroid cases with the big retrosternal that compress the trachea and that will cause some difficulty in breathing. That will change the spectrum of the surgery from a simple medium surgery to a big medium sternotomy or mini sternotomy in these cases. So before we plan the surgery, we will put the cases in the NDT in order to discuss the nature of the condition and why we are discussing these cases. These cases should be done in the presence of the pathologist, radiologist, and the nuclear medicine, surgeon, and the rest of the team, including the supportive team for the surgery. Most important part, radiologist, and discuss every single case for their management before we go to the thyroid surgery. And it has to be teamwork in order to handle that part. Based on that, we will consider having the nerve stimulator, and it's mandatory in UAE, and now we brought it to Iraq for all these cases in order to avoid any nerve injury. With this nerve stimulator, the nerve injury should be 0 or near 0 in these cases. We will go to the minimally invasive thyroid surgery with the small incision, with the team working with the assistants and with the anesthesia, with the no muscle relaxant in order to get the best result of these thyroid surgery. Once we will handle that part, the recovery of the patient should be clear, and should the patient goes home the first night or the next day, and then with or without a drain. Based on that, we can see the incision is very small with the recovery, and after 6 to 8 months, there is no more incision can be seen after we giving the new gel, which is a silicone gel for the patient. This is showing a good recovery and a good patient continuity of the care, in which after that we will ask the team after the pathology result to discuss it back in the MDT and to get the best care for the patient, whether need radioactive iodine or no need. Simple follow-up and with the endocrinologist to be available to discuss the benefit of any future treatment. From that, we can see our cancer care specialties team situated in all the satellites in United Arab Emirates, Northern Emirates, Dubai, and also in Abu Dhabi and in Baghdad. Thank you, Dr. Sadir Alrawi, Senior Consultant Surgical Oncology from United Arab Emirates for thyroid and parathyroid surgery.